So in this study, we evaluated a plasma-guided adaptive first-line treatment strategy for newly diagnosed metastatic non-small cell lung cancer. A significant unmet need in the field is to understand for patients with newly diagnosed lung cancer, who requires chemotherapy in the first-line setting as a chemoimmunotherapy regimen, and who can have immunotherapy alone and do quite well and potentially have a durable response. In clinical practice, the most important biomarker to decide this has been PD-L1 status, where PD-L1 high patients tend to get immunotherapy monotherapy, but it's not a perfect biomarker. We know some people with high scores will have insufficient clinical response to therapy, and some with low PD-L1 scores could do just fine with immunotherapy monotherapy and put off the potential toxicity and risk of upfront first-line chemotherapy. So here we asked whether using a dynamic biomarker, in this case, plasma clearance or plasma reduction in tumor ctDNA detectable in the blood, could help us make a more informed choice between these two different regimens. So in this study, we took patients with first-line PD-L1 positive lung cancer who were enrolled on the study and treated them with checkpoint inhibitor immunotherapy monotherapy with pembrolizumab for 2 cycles. We checked their plasma levels pre-treatment and after the first 3 weeks. And then we also checked their imaging scans after those 2 rounds of treatment. And for those patients who had intermediate scan results, so stable scan findings or some disease progression, which was asymptomatic, we used the plasma levels to guide our treatment decision-making. And those without a response were intensified with the addition of platinum doublet. And those who had a good plasma response to therapy could stay on immunotherapy alone. And we follow patients long-term for their outcomes on treatment with this adaptive strategy. What we found by doing this is that overall, we achieved response rates, which were about 50%, and survival times of progression-free survival of 11 months. That was at least comparable to those seen in the prior historical data looking at combination chemoimmunotherapy in all patients at newly diagnosed disease. However, half as many patients required upfront platinum doublet as those who would have needed it in a predicted fashion based on historical standard of care strategies. So we believe that using these sorts of adaptive designs may allow us to spare some patients chemotherapy upfront while still preserving a way to identify those patients who could do well on monotherapy. Now, this was not a randomized study, so certainly further randomized confirmation of this, comparing this strategy to more standard PD-L1 guided strategies would be helpful to help understand how to integrate this into clinical practice in the long term. We think promising data, and we hope will be helpful to our patients.